Hello, everyone. I'll be talking about medical management of urinary stone, a case-based approach. And here are my disclosures. The learning objectives of this talk will be one, to understand the epidemiology and mechanisms of kidney stone formation. Two, describe the current diagnostic and therapeutic recommendations for the medical management of urinary stones. And three, highlight the role of potassium citrate in the management of stone disease. We know that the problem of urinary stone disease is that it is prevalent, it is recurrent. About 50% of recurrent stone formers have just one lifetime recurrence. However, a recent review of the first-time stone formers calculated a recurrence rate of around 26% in 5 years' time. And aside from being prevalent, recurrent, urinary stone disease is also progressive. This is a nice study by Zhang et al. Looking into around 35,000 patients for general health screening, and 2.4% had radiologic evidence of kidney stones. It was also found out that the presence of metabolic syndrome was associated with a 71% increased odds of kidney stones. And we know that if you have a metabolic syndrome, you have a lower urinary pH, decreased citrate excretion, increased uric acid, and calcium excretion, all of which increases your risk for stone formation. It used to be that we consider stones as a benign disease. However, as you can see here in a meta-analysis of cohort studies involving more than 4.7 million participants, nephrolithiasis now is considered a risk factor for chronic kidney disease. And compared to individuals without a history of nephrolithiasis, the relative risk was 2.16 for the development of end-stage renal disease in symptomatic stone formers. And these are the risk factors for both CKD and end-stage kidney disease in stone formers. As you can see, female gender, being overweight, frequent UTI, presence of struvite stones or single kidney, urogenic bladder, previous history of obstructive nephropathy, and the presence of ileal conduit. And not only that, kidney stones is already associated, as you can see here in a meta-analysis by Peng et al., it is associated already with a risk for coronary heart disease and stroke. The main types of kidney stones are your calcium oxalate, which is the most common, calcium phosphate, struvite, uric acid, and cystine. And in this local study at the PGH, very, very similar. The most common type of stones, whether it's a pure stone or a mixed stone, will still be calcium oxalate, followed by uric acid stones. And how do kidney stones develop? Well, there are naturally occurring crystals in our urine. So that's your calcium, oxalate, cystine, and uric acid. And once they supersaturate, these substances form crystals. They coalesce, aggregate, and enlarge, leading to stone formation. And that's only the first phenomenon. There's actually a second phenomenon wherein it is believed that there's a stone material which is usually composed of your calcium phosphate that is anchored in the renal papillary system, known as the Randall's plaque. And this can also be a source or a reason for stone formation. And as I mentioned earlier, supersaturation of crystals is the number one metabolic abnormality for stone formation. You can also have the lack of inhibitory substances. And as you can see here, citrate is the most common and the most well-studied inhibitory substance for stone formation. Anatomic abnormalities, presence of foreign body, drugs, etc. are also risk factors for stone formation. So let's go to the first case, the first-time stone former. So you have a 21-year-old male, asymptomatic, consulted for work clearance. His father had a history of staghorn calculi and went to dialysis. Urinalysis showed a pH of 5.4 with a WBC of 1 to 2, RBC of 0 to 3. Ultrasound showed an 8 millimeter stone in the inferior calyx of the left kidney. Chest KUB X-ray was also requested by the physician, which was unremarkable. So this is the ultrasound. And what is the recommendation when you have a patient first time with an incidental finding of stone? So you already have a stone of unknown composition. So according to the latest guideline, the 2021 European Association of Urology Guidelines on Urolithiasis, first, of course, very important is to take a medical history, such as stone history, dietary habits, and medication charts. So these are very strong recommendations. And then this is followed by diagnostic imaging, blood analysis, and urinalysis. When you talk about history taking, you just really have to focus on dietary aberrations, like low fluid intake, extremes of calcium intake, high oxalate, salt, or animal protein diet, and low citrus fruit intake. Why? Because these are the risk factors for stone formation. In addition, there are certain things that you need to ask as well. Drug intake, because there are indeed stone-provoking medications, especially now in the midst of the COVID pandemic. I know a lot of people are taking mega doses of vitamin C. Those who want to lose weight takes orlistat. And then I also know that a lot of people are taking vitamin D and calcium. Okay, so this is just a sample list of drugs, and these are their metabolic effects. These effects actually predispose a patient to stone formation. So what laboratories will I request for? And the answer to these is all of the above, as recommended by the guidelines. Okay, so you have, in addition to your urinalysis, creatinine, uric acid, calcium, sodium, potassium, CBC. The CRP is for patients who you think have an infection, while the PT and PTT are for those patients wherein intervention is likely or planned. So at the very least, as I've mentioned earlier, you request for, as basic evaluation, creatinine, uric acid, calcium, sodium, potassium, and CBC. Now, in the case of our patient, we don't yet know the stone. Stone analysis is not known. So, but you have to check if there are risk factors present. So you want to stratify these patients if they are low risk or high risk stone formers. Because if they are low risk stone formers, then really the recommendation is just to do general preventive measures. However, if you consider this patient as high risk stone former, then you might want to proceed with specific metabolic evaluation if available, so that you can plan for stone-specific recurrence prevention treatment. And when you talk about general preventive measures, this is usually lifestyle modification and diet. So fluid intake. So usually the recommendation is 2.5 to 3 liters per day. However, what we are really after is the urine output volume. So I usually ask my patient to monitor or at least to measure their urine output per day for at least the next 3 days or for a week. And my target is 2 to 2.5 liters. Okay? And then you look at the balanced diet, as you can see here, one that is rich in vegetables and fibers. Okay? Normal calcium content. I remember when I was a medical student before, or even during the time that I was in residency, when we have a stone patient, we recommended low calcium diet, and that is not true anymore. Okay, you limit your salt and protein intake, and of course, adequate exercise, and try to retain a normal BMI. Okay, when you talk about drinks, of course, I'm a nephrologist, so I would tell you water, 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 especially if you are a stone former. And there are certain drinks that really will increase your chances for stone. And you call them the kidney stone risk boosters. Such that all your colas, okay, the fruit punch, they increase your risk for stone formation because most of the colas contain phosphoric acid. What about stone risk reducers? Well, you can see here there's white wine, red wine, coffee. And beer is mentioned. It apparently reduces kidney stone risk by 41%. But I have to caution, this is except in uric acid stone formers. And a lot of times, patients really are uric acid stone formers on top of being calcium stone formers. Okay? Orange juice reduces the risk by 12%. That's why one of the recommendations is to take citrus, because citrus drinks contain citrate. And remember, one of the inhibitory substances that's very important for stone prevention is your citrate. Tea also reduces stone formation. So I mentioned earlier that it's not recommended anymore that you tell the patient to go on a low calcium diet just because they have stones. Okay, in this elegant study by Borghi et al., this was a 5-year randomized prospective trial in 120 men with hypercalciuria and recurrent nephrolithiasis. Patients who were placed on low calcium diet, normal sodium, normal protein, was compared to patients who were placed on regular calcium diet, low sodium and low protein. And as you can see here, there is actually a higher recurrence for stone formation for those who were placed on a low calcium diet. Okay, so again, with kidney stone patient, the recommendation is normal calcium diet. So these are what we consider high-risk groups for stone formation. Look at the general factors. Early onset of urolithiasis, usually in children and teenagers, anyone actually less than 30 years old. History of stone formation in the family, recurrent stone formers. Uric acid stone former is already considered to be in the high-risk group. Anyone with infectious stones or solitary kidney. In addition, I'd like to point out also diseases associated with stone formation, such as hyperparathyroidism, presence of metabolic syndrome, nephrocalcinosis, polycystic kidney disease, any GI diseases, increased levels of vitamin D, spinal cord injury, and neurogenic bladder. And that is the reason why you really need to do basic evaluation. So you'd be able to check your calcium. If the calcium is high, then you could probably need to check for intact PTH to rule out hyperparathyroidism. Okay, and these are also other lists for high-risk groups for stone formation, anyone with anatomical abnormalities, and these are just genetically determined stone formation groups. What was added actually in the latest guidelines that environmental and professional factors, including high ambient temperature, so anyone working in really very hot zones, are already considered to be in the high-risk group for stone formation. You can classify stone according to X-ray characteristics. So sometimes we see stone just by X-ray alone. So these are the radio-opaque stones, and then usually these are the calcium stones. Poor radio-opaque stones are usually the magnesium ammonium phosphate stones or the apatite and cystine stones. And the radiolucent stones are your uric acid stones and the ammonium urate stone. No? So sometimes this is very important. Like if you remember in the case of our patient, we found a stone in the ultrasound, but we did not see any in the X-ray. So you might consider that the patient might have uric acid stone because it was radiolucent on X-ray. So for this particular patient, does he need metabolic workup? A lot of you might say, no, he's very young, it's just one stone. But if you really follow the guidelines, you would say yes. Reasons, as I placed here, early onset of stone formation. He's only less than 30 years old. Family history of stone formation. His dad had staghorn calculi, already on dialysis, and possible uric acid stone former because of the fact that the stone is radiolucent on KUB X-ray. So these are the 3 reasons. So as you can see here, this can be your objective indications for doing a 24-hour urine metabolic workup. In the case of our patient, he had a family history of stone, and it was his preference to actually do the metabolic workup. His presentation was before age 30 years old. And this is an example, as was mentioned earlier, even the American Urology Association guidelines for stones in 2014 already mentioned that for those first-time stone formers who are interested and those who are high risk or recurrent stone former, additional metabolic testing is recommended. So when you talk about metabolic testing, this is actually the 24-hour urine collection. okay, on a random diet and analyze for certain factors. This is an example. So you check for volume, pH, calcium, oxalate, citrate, uric acid, and the rest. However, in the Philippines, we can only check for uric acid, calcium, volume, pH, sodium, potassium, creatinine. I think citrate is already available as well here in the Philippines. Okay. The reason why you always need to check for creatinine is that you will only know that your 24-hour urine collection is adequate if the urine creatinine is within the minimum. Say, for example, in a female, it should be 15 to 19 milligram per kilogram, or in the male, it should be between 20 to 24 milligram per kilogram. Otherwise, if your urine creatinine is below that, then your 24-hour urine collection is probably not a properly collected specimen. Okay? So in our patient, he is 60 kilos. Total volume is written there, 1,800. I'd probably ask this patient to increase more his fluid intake because I want him to be putting out as much as 2 to 2.5 liters of urine a day. Creatinine, as you can see, urine creatinine is adequate. So I can say that the 24-hour urine collection is a properly collected specimen. Uric acid is high. Okay, so I put in the normal value there. So you can say that the patient is hyperuricosuric. Calcium is within normal. And as you can see, the chemistry, the uric acid is 650. Okay, so how will I manage this patient? A lot of you might say lifestyle and diet modification, but I would probably go with both lifestyle diet modification and pharmacologic therapy. And with that, the pharmacologic therapy of choice would be potassium citrate and allopurinol. And the reason for that is because we know that once you've identified a patient with uric acid stones, we know that this is very recurrent and he can develop stones right away. Okay? And uric acid stones are easy to dissolve with medical management. So in the case of our patient, as you can see here, this is the algorithm according to the guidelines. Our patient has hyperuricasuria. So here we will start in both hyperuricasuria and hyperuricemia. So we can start this patient already on allopurinol around 300 milligrams per day. You can see here also that even in patients who don't present with high serum uric acid, but present with hyperuricasuria, you need to start this patient also on allopurinol, 100 milligrams per day. And if you remember, the urine pH of our patient is 5.4. Actually, that alone will tell me that most likely I'm dealing with a uric acid stone. Okay? And the recommendation is really to alkalinize the urine using alkaline citrate. And that is an example of which is potassium citrate. And here, you can also choose sodium bicarbonate. However, the preference usually is potassium citrate because sodium bicarbonate itself will increase sodium load. And we don't want that for patients. Remember, we want to limit their sodium intake already. Okay? So when you give your potassium citrate, the dose depends on the targeted urine pH. What do I mean by that? Like for in the case of our patient, if you want to do chemolysis, which is to dissolve the stone, we try to target a urine pH between 6.5 to 7.2. But if, for example, if you just want to prevent stone recurrence in a patient who had stone before, then you want to target a urine pH between 6.2 to 6.8. What I actually do in my private practice is to target between 6.5 to 7, and that will already cover for both prevention and stone dissolution. However, I'd like to caution you, please don't do or target beyond 7.5 pH because that will predispose the patient to calcium phosphate formation. Okay? So the target is pH, maybe around 6.5 to 7. And again, according to the updated guidelines in 2021, very strong recommendation. Prescribe alkaline citrate to alkalinize the urine in uric acid stone formers and give allopurinol in hyperuricosuric urate stone formers, which is the case of our patient. And once you start them, I think what's very important to remember as physicians, we need to monitor their urine pH and adjust their potassium citrate accordingly. So we really need to follow up this patient and check the urine pH. So we should be on target. Okay. Now let's go to case 2, which is the recurrent stone former. So 48-year-old male, left flank pain with hematuria. He had passage of stone 5 years ago, calcium oxalate by stone analysis. He already had 2 sessions of shockwave. However, he did not take any medication post-op. And now he presents with multiple nephrolithiasis, but none are obstructing. Okay? So does the patient need specific metabolic workup? And the answer is yes, for the simple reason that the patient is already a recurrent stone former, several shock waves, and yet he has stones now. Okay? Now, a lot of people will say, well, what about cost effectiveness of doing this 24-hour urine collection or metabolic workup? Well, this study by Chandoke showed that a more thorough evaluation can be advocated for patients who have more than one stone episode. And in these patients, the expense of additional laboratory tests and pharmacotherapy likely is less than the expense of repeat emergency department visits and surgical management. Okay, so for our recurrent stone former, we will see here it's a properly collected 24-hour urine. Uric acid is within normal. Okay, we're talking about urine values here. Calcium is elevated, so we can say that the patient is hypercalciuric, and serum chemistry actually was within normal. Okay, so how will I manage this patient? Again, aside from lifestyle modification, we will give this patient potassium citrate and thiazide diuretic. Okay, and again, as you can see here, strong recommendation from the EAU guidelines, you prescribe thiazide or alkaline citrate or both in cases of hypercalciuria, which is present in our patient. I'd like to mention that fevoxostat was already mentioned, and it can be a second-line treatment for hyperuricosuria as well. Okay? And this is the algorithm that you can follow for calcium oxalate stone. Aside from the basic evaluation, you can do the 24-hour urine collection. And as you can see here, if you have hypercalciuria, you give this patient potassium citrate, okay, as well as thiazide. Okay, and this is just a summary. Again, very similar. Actually, the EAU guidelines and the American Urology Association guidelines are pretty much the same in the recommendation as far as thiazide diuretic or potassium citrates are concerned, as well as allopurinol in the management of kidney stone patients. Okay, so the prevention of stone recurrence is the goal of medical management. Remember, recurrence is the rule after the first stone. 11% at 2 years, 20% at 5 years, 31% at 10 years. This is just the average recurrence, okay? Now, why is citrate very important? No, you can see that for almost all types of stone, you can give potassium citrate because citrate forms soluble complexes with your calcium. It lowers urinary saturation of calcium salts. Citrate by itself, again, directly inhibits crystallization of calcium salt. And an additional effect is it alkalinizes the urine. That's why in uric acid stone, it's very, very effective. Okay. And as early as 1993, this study by Barcelo and Pak, which is a randomized blinded trial, no, of around of patients having nephrolithiasis calcium stone, those who were giving potassium citrate over 3 years had more than 71% reduction in stone formation compared to those who were just given placebo. Okay? And this long-term study done in the Duke Stone Center involving 515 patients given potassium citrate for an average of 41 months, actually for as long as 7 years. You can see here that with long-term potassium citrate, the urinary citrate that we target is achieved, as well as the pH that we want is also achieved. Okay? Maybe this meta-analysis of 4 randomized controlled trials will tell us that indeed the use of potassium citrate versus placebo reduces your risk for stone formation. Okay, 11% only for those who were given citrate versus 52% for those who were given placebo. Clearly, a 75% relative risk reduction for potassium citrate takers. What about thiazides? Well, the effect of thiazide is that it augments calcium reabsorption in the distal tubule. That's why it's very useful in patients with hypercalciuria. It reduces urinary saturation of your calcium oxalate and brucite, and it corrects secondary hyperparathyroidism. Other thiazides that can be used will be indapamide as well as chlorthalidone. In this American College of Physicians review of nephrolithiasis, which was published in 2013, and I would just like to go straight to the summary. As you can see, this is the forest plot. There are only 3 pharmacologic treatments which were found to be effective in terms of preventing stone recurrence. And as you can see here, this is thiazide, citrate, and allopurinol. Such that the conclusion of the ACP in 2013, in individuals with multiple past calcium stones, most of whom received increased fluid intake as already as a co-intervention, thiazides, citrates, and allopurinol each reduced risk for stone recurrence. I'm happy to point out that the latest guidelines in 2021 included nephrologists, because the guidelines actually is a urology guideline, but they invited nephrologists in the panel such that it was given emphasis regarding stone formation and diseases. So I'd like to just point out, when you have patients with possible calcium phosphate stone, and you really have to make sure to exclude systemic diseases such as hyperparathyroidism and renal tubular acidosis. Okay? So that's the reason why you have to request for at least for a baseline calcium, phosphorus, and very important, again, check for acidosis and urinary pH. And even for renal tubular acidosis patient, okay, still what we give is potassium citrate. Let's go to case 3, the obstructing stone. A 49-year-old male with a history of shock wave 5 years ago now presents with acute flank pain with high-grade fever. Creatinine is 84. Leukocytosis with segmental predominance. You can see here RBC is 25 to 30 with too numerous to count WBC. And what is the diagnostic imaging of choice? Okay. So you have these different choices of imaging. This is an example of a plain KUB X-ray. This is an example of a KUB IBP, ultrasound, and a non-conscious CT. Okay. Now, a lot of times we do request for ultrasound, and it's fine, no? But ultrasound can identify hydronephrosis in 98% of patients, but it can only identify ureteral stone in only 26% of cases. It's the CT scan which can identify hydronephrosis in 92% of cases and ureteral stone in almost 99% of patients when present. Okay? And that's the problem with KUB ultrasound. Okay? It's very, very poor in terms of picking up ureteral stone. So this is just to show you a comparison of the different sensitivities and specificities of your different imaging. And as you can see, the non-conscious CT has a very high sensitivity and a very high specificity, such that in addition to that, there's also this thing, what you call the house field unit. Okay, you can actually use your CT scan, okay, to your non-conscious CT to determine, have an idea of what stone the patient has, because historically, pure uric acid stone have a house field unit of only less than 400. So every time I ask for, say, a CT stonogram or a non-conscious CT, I ask the radiologist to put in the HU units for all the stones that he might find. And from there alone, I can actually say that, you have uric acid stones, most likely. All right? But if you have a HU unit of, say, 1,000, then most likely that's a calcium oxalate stone. Okay? So for diagnostic imaging, immediate imaging is indicated with fever or solitary kidney. Use non-conscious CT to confirm stone diagnosis in patients with acute flank pain following initial ultrasound assessment. You can perform a conscious study if stone removal is planned and the anatomy of renal collecting system needs to be assessed. And these are all strong recommendations. So in the case of our patient, I'd probably do a non-conscious CT scan to find out the cause of the acute flank pain. So here we can see that he has a stone in the proximal ureter, 650 HU. So most likely this is a calcium stone. Okay. And it's 8 millimeter. Okay. Patient was started on IV antibiotics. What will you next? Would you just observe with antibiotics? Maybe try to do medical expulsive therapy, refer to urology, or all of the above? It is what's mentioned that if you have a ureteral stone of less than 10 millimeter, and if active stone removal is not indicated, observation with periodic evaluation is an option. Okay? So this patient may be offered appropriate medical therapy to facilitate stone passage during observation. So that's what you call medical expulsive therapy. So it can be considered, and it's probably most useful when the stone is only between 3 to 10 millimeter in size. Overall, medical expulsive therapy is associated with a 65% greater likelihood of stone passage. And when you talk about medical expulsive therapy, it's just that it's just giving, medication to reduce inflammation, such as your NSAID. You can give alpha blockers, such as tamsulosin, okay, or nifedipine, because meta-analyses have shown that patients with ureteral stones, especially those who have stones already in the distal ureter, if you give them alpha blocker, tamsulosin, they are more likely to pass stones with fewer episodes of colic than those not receiving such therapy. Okay? So this is a grade A recommendation if you are considering medical expulsive therapy. And for those patients, you observe them within 1 to 14 days. But I highlighted this year that you only offer medical expulsive therapy if you have a patient with well-controlled pain, no clinical evidence of sepsis, and adequate renal functional reserve. And you might be surprised with this, but this was actually mentioned in passing in the updated guideline. The question is, can sexual intercourse be an alternative therapy for distal ureteral stones? A prospective randomized controlled study. And the conclusion was, so I'll just go straight to the conclusion. Let's not talk about the details. The results have indicated that at least for patients with distal ureteral stones with less than 6 millimeter in size, and a sexual partner may be advised to have sexual intercourse 3 to 4 times a week to increase the probability of spontaneous passage of the stones. But I do hope that for any patient with distal ureteral stones, this should not be an excuse to have multiple partners for you to try to pass out your stones. Okay? And how would you know the likelihood of passage of ureteral stones? As you can see here, if the stone size is less than 5 millimeter, there's really a 68% chance that you'd be able to pass out the stone. However, it's more than 5, 47%. And if it's even smaller, like less than 2, 85% chance of passing out of stone in the next 31 days. In the next 40 days, if it's between 2 to 4, and in the next 39 days, if it's between 4 to 6. So really, usually our cutoff really is around 6 millimeter or less when we try to do medical therapy for passage of ureteral stones. And we expect that 95% of these stones should pass within 40 days. Okay? However, please do remember that there are indications for surgical treatment, and that includes the 3: pain, infection, and obstruction. So in patients with obstructing stones and suspected infection, clinicians must urgently refer to urology to drain the collecting system with a stent or nephrostomy tube and delay stone treatment. So in the case of our patient, really, I will not attempt to do medical expulsive therapy because patient already presented with sepsis, acute flank pain, fever, and obstruction. I will refer to urology while I continue my antibiotics. And of course, with that, you obtain a urine culture before any surgical treatment is planned, okay, because you want to treat urinary tract infections. You offer perioperative antibiotic prophylaxis, okay? And again, as I said, the idea of knowing the Hounsfield unit is very important because if you think that the stone is a radiolucent stone or a uric acid stone, then maybe you can attempt to dissolve the stone. But again, these are only for patients without signs of pain, infection, or obstruction. However, even if our friendly urologists are able to already remove the stones, remove the obstruction, we are still left with the problem that this patient, one, will have possible recurrence of stones, and two, will even have post-op residual stones. And that is a problem because there's a risk of developing new stones from such needle. You can have persistent UTI and dislocation of fragments with or without obstruction and symptoms. And I'd like to introduce to you Steinstrass. Steinstrass is an accumulation of stone fragments or stone gravel in the ureter, which may interfere in the passage of urine. It occurs in 4 to 7% cases of patients who underwent shockwave. The problem with this is the fragments can cause ureteral obstruction, which may be silent in 23% of cases. That's why the guidelines recommend that medical, this time, after surgery, after patient was already managed by uro, then now you can probably plan for medical expulsion therapy to increase stone expulsion just in case this patient presents with residual renal stone fragments or Steinstrass to reduce the need for endoscopic intervention. Why is medical treatment necessary after stone removal? Because there is a high rate of recurrence. Surgical management of stones will not change the natural history of stone disease. Your patient will still have the metabolic abnormalities that predispose them to stone formation in the first place. So it's really very important that even if these patients were handled by your urologist, then maybe after that, you can continue managing these patients so you can already plan for medical treatment. Okay? Correction of abnormalities is the only way that may dramatically reduce stone formation and recurrence. This is a nice study by Soigor et al. In 2002 looking at the effect of potassium citrate therapy on stone recurrence and fragments after shockwave lithotripsy in the lower calcium urolithiasis, which is a randomized controlled trial. And as you can see here, for those patients who were given citrate therapy, okay, compared to those who were not given anything post-shockwave, after 12 months, those who were on citrate therapy remained to be stone-free, while those who did not continue any medication post-op, almost 30% of them developed stones again. Okay. What about patients who had Steinstrass? Those with residual fragments less than 5 millimeter. Those who were placed on potassium citrate therapy, 44% of them became stone-free. No? So meaning the fragments were actually dissolved or maybe passed out. 56% of them, the stone size did not change, while 0% of them, stone size did not increase at all. Compared to patients who were given placebo, a high 62.5% of them, the residual fragments actually increased in size. Only 25% had an unchanged stone size. Well, what's very important to look here is only 12.5% of them became stone-free. Okay, so there is a validated tool to predict a second symptomatic stone episode known as the Rox normogram. And you can find it in your medical calculator, your apps. You just put in here whatever the risk factors, um, stone composition, placement of stones, and here you will see what is the risk of stone recurrence of this patient. For this particular 30-year-old male patient, you can see here that the risk of second symptomatic kidney stone event was a high 34.7% at 5 years and more than 50% at 10 years. So you would expect that by the time the patient is 40 years old, this patient probably would have another symptomatic stone episode again. I'm pretty sure a lot of you will say, what if I can do all the workups? Okay, especially I can understand the 24-hour urine metabolic evaluation. The AUA guideline in 2014 said that you can still offer, of course, it will not stop you from giving potassium citrate to patients with recurrent calcium stones in whom other metabolic abnormalities are absent or are known or have been appropriately addressed and stone formation still persists. Because when you talk about medical therapy for stone disease, urinary stone is composed predominantly of calcium. It cannot be dissolved with current medical therapy, although if it's small, you can pass it out. So really, the very important thing is for the stone not to grow any bigger. So medical therapy is important in long-term chemo prophylaxis of further stone growth or formation. And among the different types of stone, uric acid stone and cystine stones are the one that can be solved with medical therapy. And as I've shown you in the 3 cases, potassium citrate use is beneficial in the entire spectrum of stone disease. That is, the first-time high-risk stone former, the recurrent stone former, the post-op patient, to prevent recurrence of future stones leading to surgery again. So in summary, the prevalence and incidence of kidney stone worldwide is increasing. Stone formers have a higher risk for seeking